Only 9% of doctors that were surveyed said they feel extremely confident managing their own finances. 79% of them said paying off debt is their number one financial priority right now. Not retirement, not buying a house, it's the debt. Welcome back to another episode of the podcast for doctors by doctors. I'm Dr. Michael Jerkins, joined by a special guest today. Today on the podcast, we are joined by someone who's been on the show actually before, Dr. Josh Daly. He is a practicing pediatric cardiologist at Arkansas Children's Hospital and the University of Arkansas for Medical Sciences, where he serves as the program director for the Pediatric Cardiology Fellowship. He also co-directs a medical student course, which is great, by the way, Personal and Professional Financial Essentials for Physicians. I'm not sure what the acronym there is, but I'm sure it's catchy.
There's not one.
Okay. Which equips fourth-year medical students with the essential knowledge and skills to manage their financial futures. Beyond the classroom, Dr. Daly has been leading a body of research using net present value analysis to model the lifetime financial implications of physician career choices, which is very cool. He looks at everything from how promotion timing affects earnings to whether an extra fellowship year actually pays off. And his work has been published in journals including JAMA, Network Open, Pediatrics, and the Annals of Thoracic Surgery. And it's the kind of research that actually makes you rethink the questions we've been asking about money in medicine, which is very helpful. Dr. Daly, welcome back to the podcast.
Thanks, Michael. It's always a pleasure to be here.
Seems like you've been a bit busy, I suppose, with your introduction.
I have. I wear a lot of hats, and that's one of the things I really enjoy about my job. While clinical practice is a big part of my job, it's only a part of it, and I get to do a lot of different things. And that's, I think, the unique selling points of a career in academic medicine, which I so thoroughly enjoy.
Yeah, I think we've talked about this a lot in the podcast, but doctors have a lot of lanes we can go down. It's not just clinical medicine, but lots of ways we can help the community and help our community of healthcare providers and doctors. But as you know, we at Panacea recently did a survey of physicians, dentists, and veterinarians, and those in training, just to see how they felt about their own personal finances, just to kind of learn about this group. As you know, Josh, it's not always a topic that we talk about a lot openly as doctors. So we wanted to give people the ability to respond anonymously to some of the questions. And some interesting stats I just want to start with and love to hear your reaction is only 9% of doctors that were surveyed said they feel extremely confident managing their own finances. That's only 9%. Said another way, 91% don't feel extremely confident. 71% of those applicants actually rated their confidence at 3 or below on a 5-point scale. The other interesting thing is of that group, those doctors surveyed, 79% of them said paying off debt is their number one financial priority right now. Not retirement, not buying a house, it's the debt. Does any of this surprise you at all?
No, I'm actually encouraged by the numbers with regard to confidence in managing their finances, because I think it appropriately matches the skill that I observe among physicians day in and day out with regard to finance. The most dangerous combination is when knowledge and skill are low and confidence is very high. And that certainly exists in some, but at least among the respondents in your survey, it would suggest that the vast majority have low levels of confidence about their skill. And I think that's probably overall appropriate, given that physicians, the vast majority of us never have any formal training in finances. And then we're kind of thrust into the market after residency or fellowship and have to figure out a few things on our own in the midst of juggling a busy clinical schedule. That part doesn't surprise me at all.
And confidence to competence ratio, it's nice to have a healthy balance, said another way. And out of the high stress that doctors feel about finances, debt seems to be overwhelming number one priority, with actually 88% of those respondents saying the student loans is actually their number one source of debt, but also concern related to debt. To me, I mean, obviously I graduated with a lot. I think you also had a decent amount too. Do you feel like this is normal, or are you surprised by the 88% number of student loans being the number one source of debt for this group?
I think this doesn't surprise me when you look at the underlying demographics of the respondents, which skews younger. So if you're surveying trainees and recent residency and fellowship graduates, I think that fits with what I see day in and day out. If the survey had included more respondents in their 40s, 50s, 60s, or those who are retired, then I think other issues would probably rise. And that reflects the fact that as a new trainee coming out, they often have, as a resident or fellow, they have a relatively modest income and a debt that significantly surpasses that. And we make relative assessments. So we compare that debt to what they make at that point in time, or their overall net worth, which is typically negative. And so it feels somewhat insurmountable. And then you combine that with just the uncertainty surrounding the student loan landscape with regard to what's changing politically, the opportunities for the possibility of forgiveness, but it may not be there, what interest rates are. When you have uncertainty combined with a very large number, that really fuels this fear.
Yeah. I think obviously to just folks transitioning, especially if you transition into residency or fellowship, you've not had to manage them before, certainly not going to feel confident about that. And the next step when you go into practice and you're really having to make these tough decisions on, do you pay more than the required amount? Do you enter into a different income-driven repayment amount? Do you refinance them? There's several new decision points that you really didn't necessarily have to address in the previous career stage. I'm curious because your work, we mentioned this at the outset of net present value of these big career choices that we make and doctors' lifetime earnings. Walk us through how you think through doctors' debt compared to how much they actually are going to earn over their lifetime.
That's a great question. And the tendency is just to add up all of your earnings over someone's life and compare it to debt today. And that's not really an apples to apples comparison. That's because of the time value of money. So $1,000 today is far more valuable than $1,000 in 10 or 20 years. So you need to account for that. And one of the ways of doing that is this net present value analysis, where you can discount future dollars to today's dollars. So what I can actually do is I can look at, for instance, the life career earnings of a pediatric cardiologist, and I can discount it to a lump sum of dollars today. So in my case, that's probably between, depending on how you do the math, somewhere between $6 and $8 million is what a full pediatric cardiologist's lifetime earnings is worth in a lump sum of money today. And if you compare that to $200,000 in debt, obviously that debt is dwarfed in comparison to lifetime earnings. But it's really hard to envision. We don't have an intuitive sense for this, what a lifetime of earnings may look like. We rather anchor on starting salaries. So in my field, if a brand new pediatric cardiologist makes $230,000 or $240,000 a year, yet they have $300,000 or $400,000 in debt, that tends to be the comparison that we end up making, and we make decisions and respond emotionally based on that, even though in the context of a full career, debt isn't a huge impact compared to actually how much you'll earn over your lifetime. And there are other variables that actually have a greater impact than your student loan debt.
It's tough too, especially when you compare the path you chose versus what it could have been if you had chosen a different career path, and wondering what if, and wow, I could have been way better off financially if I didn't have so much debt. But when you take into account the lifetime of earnings based on that path you chose, maybe it doesn't look so bad. I mean, what's interesting is we got several quotes from respondents. One of the quotes was from an attending who's an orthopedic surgeon who said, "I like what I do, but I could be so much further ahead financially had I chosen another path." That's orthopedic surgery, one of the highest paying medical specialties. How would you talk to that person as far as trying to understand their relative lifetime earnings versus what they might be seeing on these alternative paths?
Well, first, I'd want to ask some questions in terms of basically, why do you think that? Why do you think you would have been better off? In other words, what's your comparison group you're comparing yourself? Is it a buddy of yours in college that went straight in and became an engineer or started a company and made a ton of money? Is it somebody that you see on social media that has a huge net worth even in their 20s? Is that your comparison group? I think we tend to draw those comparisons, and that fuels this idea of the grass is always greener. When you actually look at the numbers, though, as physicians, we have it really good, especially orthopedic surgeons. One of the things I love to do with fourth-year medical students, so they're about to transition to residency, and many of them are lamenting how much that they'll make as a resident and that it isn't anywhere near what they think they're worth as a physician. And they talk about, I don't make enough to save. And then you actually present the numbers about typical Americans. And residents make what a typical American makes, like the median, not on the lower end. When you look at some of the later data, so the median income for someone who's working full-time in the US is like $63,000. The median income for a whole household is like $83,000. And a resident typically earns somewhere in the 60s. And every physician who works full-time after residency or fellowship works significantly more than that. So when you actually look at the numbers, we do really well compared to them. Now, if you compare yourself to someone that's made a huge amount of money at a very young age, then there's another variable, and that's survivorship bias. So we look at the person, let's say, that tries to start their own company, and you look at those that are successful, who are worth hundreds of millions of dollars, and you compare, say, I'm in my 30s and have a negative net worth, and then this other person is worth 30 million or 100 million. What you don't compare yourself to is all the people that went down that path and their companies went bankrupt or never made it and earned very little. So you tend to compare yourself to these outliers. One of the wonderful things about a career in medicine is that while you're not going to earn hundreds of millions of dollars in your life, you're guaranteed a good income as long as you don't do something ridiculous along the way. Every physician who works full-time earns more than the median income in America, and you can live a good life with that. The range of options is not as great as there is in a lot of other areas, but that disbursement is all in a very livable wage. And so a lot of physicians don't recognize that. So if you were comparing, let's say you're 23 and you could go to medicine or you could go into some kind of tech, something or other. What are the odds with each of those paths that you'll earn consistently over 100,000 a year during those? The odds of that during the medical path are much greater than the odds going another direction. If you get into residency, I'm a fellowship program director. It's almost impossible to fire you. Like if you have a pulse and don't do something ridiculous, you will graduate residency or fellowship. And then you'll earn a reasonable income unless you do something ridiculous. And I think we often don't realize with medicine that downside risk is so unbelievably low. And there's a lot of benefit that comes with that.
Yeah, it's over 99%, more than that, folks who enter residency finish one. So the numbers are pretty darn good. Now, it's interesting. We talked to residents in this survey, and we asked what was the thing that the resident felt like they needed most, whether that be call schedule or pay. It really was. So one responded, that's a pediatrics resident, said financial literacy resources for resident doctors is what they needed. What's interesting is we can, at Panacea, actually do something about this. We have a huge resource library. Some of the work's actually from you, Dr. Daly, are on there. We'll make sure we link to that resource library in this episode in case that resident is listening. But one is I applaud this resident for saying, hey, like I kind of know what I don't know, or I understand what I need to learn more about and have the insight to do that. In my experience, most residents are trying to survive and learn their clinical skills. And in the financial realm, they don't really know what they don't know, and they're just trying to progress to the next stage, and they'll figure it out later. But that later doesn't actually really happen. I don't know what you see with residents and fellows.
My experience would match what you have described. I applaud this one resident for recognizing his need in that area, but I don't think that fully reflects the experience of most residents. Rather, they're working hard, and they have this belief that if I just get the residency to fellowship, then I'll have all this time available to do these other things. So they defer so much, everything from saving for retirement to paying off student loans, even learning the basics about finances. And when you look at the actual data, like around burnout and so forth, this expectation that you finish training and your life is so much better doesn't materialize. A lot of junior attendings still work very long hours. And in many cases, more similar to what residents work, as resident work hours have come down. And then you throw in all these extra responsibilities that we don't anticipate. Everything from things professionally, from owning a practice, to just in your personal life. You tend to have kids, and multiple kids in your life gets busy. And so I certainly didn't experience that in my own life. And I think most physicians don't as well. This all of a sudden, all this free time that supposedly you have when you're an attending to read books on finances. If you can't do it as a resident, you're going to struggle as an attending too. Like you just need to make it a priority.
I agree with that. But how do you address the dentists in the crowd whose work schedule may be slightly different on average? You know, most dentists and specialists that I work with or have worked with is on a 4-day work week. And now the 5th day is like, you know, administrative perhaps, et cetera. But the hours may actually reflect, hey, I finally made it. My work hours a little bit different. How do you address that with our dentist colleagues?
Well, one, I don't have a lot of tremendous experience with that, so I'll defer a little bit to your expertise there. But I would think as well, how you handle, in that case, that transition from finishing training to starting your first job, in many ways probably establishes a trajectory for your life. So if you immediately spend all of your new income, You work 4 days a week, and then your extra time off is spent doing all sorts of other stuff, especially in the domain of consumption items. And you don't go ahead and build in time to grow in financial literacy, to learn some of the basics, to manage your budget, then you're probably not going to do that. But there's that window, periods of transition, we're very ripe for change. And so even if you look at the science of human behavioral change, leveraging those transitions for your benefit, there's a lot of wisdom to that. I would suspect dentists have that opportunity as they finish training and get their first job. But I obviously haven't gone down that path.
I was at a dental school yesterday speaking to dental students, and it's just one of those things where kind of similar to the resident story I just said, is they're just trying to survive in advance, learn their skill, and eventually one day they'll figure out the student loan piece. But the amount of information they had on the new payment programs, and like there was next to no knowledge in that room. Like, I'm not bashing them at all. They're just busy being learners. And there's a big gap to fill where they are now when they're in training versus when they're in practice, what they actually should know to be able to make wise choices. And you and I have talked about this, but I even talked about it yesterday to the dental students. How many dentists do you know that look like they don't have a lot of money, or live in a small house, or have a car that's 15 years old? Like, most don't. Does that mean all of those people actually have a financial life that's healthy? No. It's because we actually make enough money to do dumb things and still on the surface look like we have it all together. But if you looked at their retirement accounts, it tells a different story.
Yeah, I think that one is true of dentists, but is true of wealthy Americans in particular. There's the excellent book, The Millionaire Next Door, that looked at basically who are wealthy people in America and who do we think they are. And the bottom line is those that spend a lot of money are often not those that have accumulated a lot of wealth. It's like the guy next door that drives a 10-year-old, Toyota Camry, who may have a tremendous amount of wealth. It's not the person driving luxury automobiles with a huge house, taking vacations to Europe and the Caribbean. Many of them may actually have very little net worth.
Yes, and just to be fair, I wasn't trying to say that was just the dentist doing that, but physicians and vets too included. And as we talked about yesterday, and I've talked about in this podcast, this is from the psychology of money, so I didn't originate this, but the concept of wealth being really the ability to control your time. Like, you're not putting yourself in a position to control your time if you're constantly just living in debt, trying to keep up with the Joneses with the consumption. But I want to transition because we've talked a little bit about how debt's stressful, financial wellness is stressful, being a doctor, going through the training is stressful. Yet, what's interesting is when you look at the match, so on the medical side for residency, we had a career number of applicants in the match at 53,000. So it's interesting is you have all of this financial pressure and the headlines of, reimbursement being less and debt being high, yet we have more than ever people trying to get into residency. What do you make of that?
I think there are probably multiple drivers of that. It's not as simple as one in particular. One of those is that there's more medical students in the US than there ever have been. A lot of med schools have kind of popped up in different areas, so that increases the demand for residency positions. In addition, a large percentage of those applicants are foreign medical grads who, in many cases, stand to have a much better life and earn a significantly higher income and practice medicine in a different way in the US. And so they greatly desire to have that US medical training. So there's those two contributors. And then additionally, it goes back to some of what we've said, that there is a path to the good life that goes through medicine. And many of us doctors, we tend to focus on the negative side, that we don't earn as much as we think. We have to see too many patients. But at the end of the day, we earn a great income and we're engaged in meaningful work. And there is a demand for both of those, especially among those in their 20s to 30s, both to have a guaranteed good income, regardless of what happens to the economy, and then to actually make a difference in what we do. And there aren't many other areas in our economy where those two pieces come together like they do in medicine.
And that is interesting because what I hear you saying, it's a lot of times we frame these conversations as, is it a calling or is it a career? And there's especially the older generation of doctors talk about the younger generation not viewing it as a calling. But you kind of actually say maybe it's not either or, but maybe it's a little bit of both.
Yeah, and actually, so I think it's helpful to step back for a moment and talk about the three lenses through which we tend to view vocation. But this is one way of thinking about it, and that's actually job, career, calling. And so a job is like what you got for your summer when you were 16. For me, I was a lifeguard at the pool behind my house. And it's something you get for a short period of time. There's no intention of staying in that space, and you earn money for that short period of time. A career is something that you intend to remain in for a longer period of time, and it offers both longevity and an upward trajectory. But you may not find the work meaningful, or it doesn't make a difference in lives, so it's not something you enjoy. A calling is work that you find you're deeply intrinsically motivated to engage in, and you feel as though it makes a difference in the lives of others. And there's something beyond or greater than yourself calling you into that. And the tendency when you hear them described, say, oh yeah, we should pursue a calling mentality. Well, that's actually not, from my perspective, the case. There's some real downsides to each of those mentalities, and there's some pros to those. So for instance, a physician that fully adopts the calling mentality is really sets himself or herself up to be taken advantage of by hospital administrators, because they're not going to negotiate on their behalf. Suddenly, when someone has to take call that weekend and the administrator says, you have to do it, or a kid's life could be in danger, you're going to step up and do it. And so the sacrifice there is to their own life, burnout, their families, et cetera. There have been many, many, many children of doctors who fully adopted a calling mentality who have been really upset with their parents as a result of that. So there are some real downsides. And I think you see that with a lot of the new trainees, and there are many that view it somewhat from a job mentality, like a locum's job. That's a classic job mentality. You give me X amount of money for this knowledge and skills for this amount of time. Or they may adopt more of a career mentality. And what I think is probably the healthiest approach is not to fully adopt one, but to recognize some of the benefits of each and to bring them together. And while calling, I still think, at least from my perspective, should probably predominate, to not give yourself so fully to that you're taking advantage of, to recognize those other pieces. And that, like for you and me, we're far more than just a doctor. That's another downside of a calling mentality. Your identity you drive primarily from the work you engage in. And then when you retire or suddenly you become disabled, like your identity is at stake. And so that's a downside. But having different aspects of your identity anchored in different areas as well also protects you in those situations. So I think it's helpful to view it from all of those lenses and to bring those to bear as you think about your own job and where you're at.
Yeah. And eventually there is a price in which people won't pursue a calling, right? And I don't know where that is exactly, but things are going to get more expensive coming up for trainees. And I want to pivot a little bit because, as most people know, with the One Big Beautiful Bill Act, there were changes to student loans and federal student loan policy in which medical, dental, and vet students would, entering into their first year in July and August, will not have access to Grad Plus. So what that means is they can borrow up to $50,000 annually from the federal government, and it will cap at $200,000. The problem is not all dental, medical, or vet schools only cost $200,000. They might actually cost $300,000 or $400,000, which means, in my estimation, probably around half of borrowers in their first year of medical, dental, or vet school will need to go to a private lender because they will max out their federal loan at $50,000 and need to go to the private markets and figure out the loan. So when you heard about this cap, when you heard about the $50,000 a year cap, what was your reaction?
Well, one, just a lot of confusion and uncertainty surrounding it. I'm grateful I don't have student loan debt anymore, so it didn't directly impact me. So fear didn't predominate in the way it would have had I been about to start medical school. I think I would have been very afraid in that scenario. But the other thing that, from where I sit, that as I think about that, I recognize there's uncertainty. We're really not sure how it's going to shake out. And when there's a big change, the headlines that tend to predominate are those that catastrophize, talk about how terrible it is. And yes, we need to think about it, but it may not be as terrible as we anticipate, especially if companies like Panacea and others recognize that, as we said, if you get into residency, you're a pretty good bet that you're going to earn a good living. And so if they make loans available at a reasonable rate, recognizing that that's a pretty safe bet, then it may be that companies like Panacea can step in and fill some of that void, or the political landscape may shift. There have been so many times I anticipated one thing would happen and something else ended up playing out. So we'll see. That may all come to pass, and it may end up being a bigger deal than we anticipated. However, I suspect it'll be more in the opposite direction. It'll be important, but won't significantly shift the number of medical students pursuing medicine. But I could be wrong.
Yeah, it's interesting because I think that definitely could be true. I think that there will be, by kind of our internal estimations, maybe 14, 15% of those first year med students that need a private loan but can't get approved because they don't have a well-developed credit score yet because they're, young and haven't had much experience. And that's a problem, right? Because then in theory, if that holds up, which of course we'll see, is you probably then will have empty seats that will then get filled in theory with folks who don't need a loan. So then are we kind of skewing even more so the population of doctors to those who can afford it without debt, which has its own downstream implications, obviously. One thing that's interesting is, so we had a doctor in our survey that talked a little bit about just this debt piece, who said this: I accepted the debt burden when I started medical school because I knew I had repayment options, IBR, PSLF, but if forced to take out six figures of private student loans, that would be a significant barrier, and I'm not sure if I would choose to risk it. And that's the crux, right? It's not just the number, but it's also these repayment options and the less flexibility that are going to be available to them. And I'm really curious on how that will affect people down the line after residency.
Yeah, I'm not sure how it's going to all shake out, but there's some real significant implications, especially with workforce diversity, as you mentioned, that I think need to be given serious consideration and some real thoughtfulness, and not just arbitrary changes like often seem to be made.
Yeah. I mean, I guess if you were to, and I've actually had these conversations recently, but I don't want to just to make it sound all negative and this is bad and best of luck. But if you're a med student or really a pre-med student or pre-dental, pre-vet that's about to start in the fall, what's a useful thing that you would tell these folks in regards to how to face this new federal student loan cap?
One, are you saying in a scenario in which they would need to borrow beyond that student loan cap?
Exactly. Yes. In general, but also if they're facing down a bill that would mean they need to borrow more than $50,000.
Yeah. I would, one, encourage them that I think it's unlikely that they would start medical school and suddenly a bill would be due and be more than with no way of paying it. Because there's lots of other stakeholders, like those in the med school don't want first and second year med students dropping out either. And so even if they're not really thinking about them even out of self-interest, there's probably going to be some other stakeholders that are going to step in and keep some of that from happening. That's what I suspect. I could be wrong. And then I would encourage them as well that if you can get through medical school, which most med students can, and get into residency, then you stand to earn a significant income. Now, if you have this expectation, I'm going to live like a rich doctor and have all these consumption items, you're setting yourself up for first frustration. But if you have reasonable expectations, even with a larger student loan burden, of which a large percentage is composed of private loans, you can still pay that off and have a really great life and have a great career.
Yeah. Well, that's what's interesting too. We talked a little bit about the medical space, but obviously we have veterinarians and dentists that are listening to this as well. And, they have a lot of debt, those populations. AVMA, average real income for veterinarians in 2024 is around 154,000, and new graduates finding full-time work average salary starting in 2025 was around 130,000. Dental graduates going into private practice, also the vets going into private practice, aren't going to qualify for PSLF because they don't have a qualified employer. So how do you talk to especially the dentists and vets, and there's some medical specialties too that just tend to not have qualifying employers available to them? How do you advise those folks on handling their student loans when PSLF is off the table?
They need to take it seriously is the bottom line. And they need to plan on paying it back and not having it forgiven. I had the benefit, mine were forgiven for public service loan forgiveness. And I'm so grateful for that. And it made my life easier. And that is a very real chance that they may not exist for future borrowers. So they do need to take that seriously. And especially at periods of transition, primarily from ending training their first job, they need to carve out a lot of that to get out of debt quickly. Debt is like a millstone around your neck. I mean, it is hard, both on an emotional level and then on a practical level. And taking it seriously and having a plan to get out of debt, I think is really important. And that's reflected in the survey results you talked about. I think these students and early doctors recognize how much weightiness is attached to that and are taking it seriously.
And taking it seriously, you want to see, as we've already mentioned, how does this debt affect you over your lifetime earning money, not just right now? And how do you step back and actually see the investment you made and how that could be paying off your return on investment over a lifetime. And I want to go back to some of your research of net present value analysis, looking at your career earnings and what does that translate into dollars today. I would like to start with one of the findings that I think should be required reading probably for any medical student, which is promotion. When do you, especially in an academic setting, when do you get a promotion? What's the promotion timing? Your research in the JAMA Network Open found that in many specialties, when you get promoted had actually a larger impact on lifetime earnings than what specialty you chose, which I am very surprised about. Delayed or absent promotion, we're talking that losses that can be, hundreds of thousands to even several $1 million. It's a lot. So how do most trainees right now think about promotion, and what should they be asking that they're not?
When I finished fellowship, I don't even think I understood the difference between an assistant, associate, and full professor. That had never been explained to me. I had a vague sense that probably was something more on the academic domain, but I did not understand the financial implications. So for those listening here that may not understand how it works, within academic medicine, typically you're hired as either instructor and assistant professor rank, and then you go through a series of promotions. And those promotions are not primarily a function of just how good of a doctor you are. They tend to relate to research productivity, teaching, clinical output, review generation. It depends on where you are and what the rules are at your institution, kind of what you're hired by. But if you play that game well and you get promoted, usually you get a pretty significant raise with each of those. So for instance, in my specialty, when I went, if you go look at an assistant professor at the 50th to associate professor, that's like a $60,000 to $70,000 a year raise. And then the full professor is almost $80,000 a year raise. And once you get that raise, you have it the rest of your life. So there are scenarios. I've been blessed and I've been promoted relatively quickly. So I'm 11 years out and just became a full professor. And that means if I work another 25 years, that's an additional 25 years of full professor pay compared to many of my colleagues that may remain an assistant professor their whole life or an associate professor. That raise is far bigger than any kind of raise I could get from a clinical production perspective. If I hit some RVU metric, it just pales in comparison to the raise I get with a rise in academic rank. Interestingly, it doesn't impact all specialties the same way. So pediatric subspecialties, our pay is more greatly determined by our academic rank. Whereas in the adult specialties, there's a little bit tighter clustering. So that's even one of the modifiers in looking at the pediatric adult pay gap. And one of the things that I encourage pediatric specialists to prioritize. One of the ways they close that gap a little bit is by making sure that they're jumping through the hoops to get promoted as quickly as possible.
Especially on the ped side, I guess. And I want to talk about that. So your research found with these pediatric versus adult pay gap on the medical side for physicians, your research found that the gap has widened over the past decade, and it's most pronounced at this assistant professor level, which is exactly the moment when trainees are deciding what to pursue. So what should, what you're really saying that these financial signals for at least early career doctors may be steering them away from pediatric subspecialties or pediatric in general. Like, is that what's happening?
It's not may, it's they do. I mean, there's a lot of research, at least looking at the reported attitudes of trainees and why they pick what they do. And pay is certainly one of the primary determinants in that. And they tend to anchor on starting pay. And the gap between adult and pediatric specialists is the widest at starting pay, assistant professor pay. And if you look broadly at pediatrics and pediatric subspecialists, we have really struggled to recruit in the last few years. There's been a lot of positions that have been unfilled, both with pediatrics and all the fellowships. And there's a big push.
Is that surgical versus non-surgical the same?
No, so interesting. I have another paper coming out looking at something called market optionality. And so it's this idea, so it does not exist among the surgical specialties, which is really interesting. So if I'm a pediatric cardiologist and I make 25 to 30% less than my adult cardiology colleague at the same academic rank, roughly speaking. That's primarily driven by the fact that so many of my patients have Medicaid and most of theirs do not. And then also the way that productivity is measured as some adult metrics in terms of RVUs that's poorly applied to pediatrics. Those are the primary two drivers. But at the end of the day, I can't tell my institution that, hey, you're not paying me enough, I'm just going to go do adult cardiology because I'm not trained to do that. But if you are, for instance, let's say you are a cardiothoracic surgeon and you do an extra training and do congenital surgery. If the children's hospital said, no, you're working among kids, we're going to pay you less, then what is the surgeon going to do? He's going to, I'll just work in the adult world. And so he has that market optionality of working in the adult world. And so they have to pay at least the same, if not a premium, to get them to do pediatrics. So that pay gap does not exist in the pediatric surgical specialties like it does in the pediatric medical specialties. And I think it's primarily because of supply and demand and market optionality. And then ultimately a children's hospital will pay you what they have to pay you to get you to do the job.
Mm-hmm. What's interesting about that is there's all these training questions that we face, especially like the ped side, like you mentioned, but also it's, well, there's this 1 year extra fellowship that I could do, or 1 year of research with my training I could do. It's always this one more year question. I remember when for med peds in my training, the big thing that was starting to happen was pediatric hospitalist fellowship, which I still don't understand why that's necessary. But I know there's people listening that could explain it to me. Like, this is a huge deal when you think about the lifetime earnings that you could have or couldn't have by delaying, being an attending by 1 year. So when is additional training actually a good financial choice?
So I can speak with certainty in the pediatric domain and more broadly in the adult domain. So the fellowship training that results in a positive net present value, so in which it's a financially advantageous, are cardiology, neonatology, critical care, and emergency medicine. And everything else is a loss. You would have been better off, from a financial perspective at least, going and getting a job as a general pediatrician than doing an extra 3 years of fellowship and then becoming an infectious disease doctor or a nephrologist or fill in the gap. And when you look at the specialties that don't fill, guess which ones it is? It's those. I mean, it very closely matches pay, which also speaks to the fact that trainees are thinking about that. That's a big motivating factor in those decisions.
It's crazy because I didn't know those specialties, but it's also crazy. Those also, the market's kind of almost like it's not corrected, but that's why they're not filling, right? There's the people that are market participants understand that. Wow. I used to think that the only one you made money that was worth it was pediatric cardiology, but I didn't realize emergency medicine was in that group as well.
Mm-hmm. Now, it's not tremendously advantageous, but it's at least a wash and you end up a little bit better off. And in those, our tendency is to pick one variable and make decisions based on that. But when the numbers are really close, we might say option A is a little bit better than option B, but if they're really close, they're functionally the same. And in all those cases, I wouldn't pick pediatric cardiology just because you make more money. I would pick it for other reasons, but also weigh that partly in the balance.
Which pediatric subspecialty had the worst or the most negative net present value?
I believe it was infectious disease, if I remember, or adolescent medicine. They were both right at the bottom. Interestingly, so related to this, I'm not sure if you're aware of this. Just a couple weeks ago, the announcement was made that the pediatric subspecialty fellowships are going to be transitioning from 3 years to an option of 2 years. And the details of that have not been sorted out. And I found out, like everybody else, even though I'm a fellowship program director, and all the fellowship program directors are kind of confused about what this is going to look like. But supposedly in 2 years, this is happening. And that's in large part for this reason that we're talking about, that we're not getting people to do fellowship training. So this belief is, well, what if we shorten it to 2 years and then we can get more people to do that? How that's going to shake out and what that's going to look like, nobody knows. But this is a big problem and people are trying to address it in different ways. I don't know that I think this is the best way of doing it, but this seems to be one of the ways that those in leadership are trying to fix this.
Do you think you can adequately train a pediatric subspecialist in 2 years?
So I can speak to it from cardiology. I hesitate to speak with too much certainty in areas I don't know, but no, I don't think that. That being said, of course, I trained for 3 years. And I think I'm a good cardiologist. So most people that did something hard are going to think that hard thing is necessary for future people. I recognize that same bias influences me. But if anything, the complexity of our field, the number of knowledge and skills you need to know has grown significantly in the last 10 to 20 years. So to believe that somehow we can compress that training from 3 years into 2 years and we're still going to have trainees that have the same level of competence on the back end while simultaneously they've been working less during that whole time, I don't see how that's going to work. But I could be wrong.
That's interesting. Going back to the $200,000 or the lifetime cap for borrowing for medical, dental, or vet school, it's going to be interesting how this that impacts career choices. And actually, we surveyed this. We asked doctors or respondents, would they choose medicine again if they were starting with the $200,000 cap? 27% of respondents say they would not choose medicine again if they were starting over with this $200,000 cap. Interesting. Another 26% said they're unsure. They don't know if they would choose medicine again. That's over half of the doctors either out or undecided. I mean, are you surprised by that? Is that number low? What do you think this really will affect career choice?
Well, one, I think it relates to the uncertainty surrounding that. So that question is in the midst of no one really knowing what's going to happen. So that tends to elevate fear. Second, there's the focusing illusion. If you're asking questions about that specific variable, and they just answered questions about it, and then you ask, would you pick medicine again? Then they're going to be correlated because they're thinking about it, focusing it, and it arises importance in their mind. And then additionally, most of the respondents were younger, either trainees or recently out of medicine. So their focus is on debt in large part. We'll see how it shakes out. At the end of the day, we'll have to look at behavior. And behavior is a function not only of what medicine looks like, but what alternative pathways look like. And so you have to look at the overall economy in the US and what other alternative paths there are. And there's a lot of uncertainty across the economy right now, especially with AI. So we'll see how all that shakes out. I think we really don't know.
I would like to close out with some rapid fire true false questions. Really not questions, they're statements, and you tell me if you think they're true or if they're false. Some are easy, some are not so easy, but let's give it a shot. True or false, nobody ever actually taught you how to read your first attending contract.
True.
No one did that for me either. I don't know of any physician, dentist, or vet actually had that training. How about this? True or false? At some point during medical training, you made a financial decision that you still think about.
Not actually a mistake, although I think it's worded as if it's a mistake. I mean, the decision I made is to pursue medicine, and I think about that a lot, and I'm really grateful I did. So in that sense, yes.
Well, then I guess that helps me answer this next question, which is true or false, you would still choose medicine again?
Definitely. Yeah.
True or false, you would still choose pediatric cardiology again?
Yes. Not as definitely, but yes. Mm-hmm.
What would be your alternate universe? Dr. Daly is not a pediatric cardiologist. He's a different type of doctor. What is this specialty?
I'm actually not sure. I think there's a lot of things I could have engaged in that would have been deeply meaningful and I would have been intrinsically motivated to do and had a great life.
You know what's funny is I can see you being a pediatric nephrologist, but y'all are arch rivals, nephrology and cardiology. So I don't know what that says. Maybe you're just two sides of the same coin, pediatric nephrology and cardiology.
We just make more money than they do.
Apparently, according to your research. That's right.
Yeah.
All right. True or false? Last one. True or false statement. Doctors are more financially savvy than they give themselves credit for.
False.
Why is that? Why do you think?
Well, so I think there's a confounder there, and it's gender. I think among male physicians, I think our estimation of our knowledge and skill outpaces our actual knowledge and skill, especially in the area of finances. I think females tend to undersell themselves, broadly speaking, and they often are more skilled than they actually give themselves credit for. So I think gender is a really big confounder with the answer to that one.
I'm not surprised that I would ask you a simple true-false question and you would make it very nuanced. That's very thoughtful of you, Dr. Daly. No, it's great. I love it. I always ask this question at the end of a podcast. You've already answered this maybe a couple of times now, so apologies. I'm going to ask you the same thing. But what is something you've recently changed your mind about?
This is going to be really specific, but I'm writing a book on this now, and that's how Christians can make decisions. And I've been wrestling a lot with the role of the Holy Spirit that intersects with cognitive bias. And I think I had erred so far on the rational side of being able to basically look at the decision that anyone makes and point out the cognitive bias in it and why it's not actually God. And I think I'm starting to come back in the other direction. So that's it. Within the last few days, I've wrestled a lot with that, and I'm recalibrated.
Wow, a few days. That is pretty recent.
Mm-hmm. Yeah.
Does that mean you got to rewrite your book?
No.
Okay.
I'm editing it. I'm recognizing the pendulum swung too far in that direction, and I need to kind of bring it back a little bit and leave a little bit more room.
It's a good sneak peek for your book.
Michael, can I ask you, I didn't get to ask you, would you pick medicine again? Obviously, medicine's now a small part of your life.
Yes, I would.
Would you pick the same specialty?
Yes, I would. You know what's interesting is I was on the campus of my medical school just yesterday for the first time. I walked in, and I will say my body felt a overwhelming anxiety. I didn't choose to feel that way, it's just what it did. But there's so much positive and stressful memories of medical training. But ultimately, I agree with you. There's no job, I think, that would, for me at least, provide as much meaning given the role we can play in helping somebody. That's just for me, and that's not for everybody. But that is something that I would never want to give up. So yes, I would definitely choose medicine. I love med peds because it gives you variety to be able to treat patients of all ages in a variety of settings. Med peds is like, we tend to wear a lot of hats, so that fits me pretty well.
It does. Would you still have gone the route of founding Panacea at the time you did if you were to go back and do it again?
I would probably start it earlier since I knew what I was doing. But yeah, I mean, we started really in residency and with just a simple idea and frustration, not knowing how to actually operate a financial services company, not knowing how to do all these things. So I would say, hey, day one, let's get going. I kind of know the playbook now. I would love to help people sooner. But really, I think it goes back to we're just trying to look at doctors and figure out ways we can solve their financial problems. That's really pretty simple. I just know more now than I did. So I would probably try to pour gasoline on the fire a lot earlier if possible.
I find it interesting. So you pursued two careers that have very different distributions and outcomes. So you have medicine with a set of skills where you're going to earn a good income with a narrow range of outcomes. And then you're a founder of a fintech company with a huge range of variation of what that can look like. And simultaneously pursue, it's like you get to benefit from the upside of one while your downside is limited by the other. You probably combine those better. You're probably, if you were to somehow estimate the future value of your decisions, you probably hit an ultimate by combining those two together in the way you did.
It's interesting you say that because I thought back to your delay in training or whatever. And I deferred med school for 2 years to go teach elementary school kids, middle school technically. And there was maybe someone even listening to this podcast that made sure they sent to me the impacts that made over my career of earnings by delaying 2 years of physician salary over the lifetime versus 2 years of a middle school teacher in the public school system. And it's not great. It wasn't great economics, but it was an experience I knew that I wanted, and I wanted to pursue it, and knew I never had the chance again. So for me, it was less a financial decision and more of an opportunity decision. And maybe I just have a lot of FOMO. I didn't want to miss out on that opportunity. I didn't know that you were interviewing me, Josh. This is really turned the table.
Sorry, Michael. Sorry.
No, it's great. You turn the tables. I love it. Keep me on my toes. I would like to make sure people can find you and your amazing work. So where can people find more about you and all this work you've referenced?
The easiest way is to go to my website, joshdaly.com. And I have links to blog posts and my academic writing, all that are housed there.
Amazing. Well, Dr. Josh Daly, thank you for joining us. If you guys love Josh, which I do, go to joshdaly.com. You can find more of his work. Ask him lots of questions. I'm sure he would love to talk to you about his work too. Thank you for taking the time to join us today.
Yeah, thanks, Michael. As always, it was a pleasure.
Thanks for joining us this episode, and you can catch the podcast for Doctors by Doctors on Apple, Spotify, YouTube, and all the other major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. To submit topic suggestions or guest suggestions or questions, you can reach us at podcast@panaceafinancial.com. As always, thanks for listening, and the next time you see a doctor, maybe you should prescribe them this podcast. See you next time.